Okay, everybody, we're going to just make a start. So can I welcome everybody to Parliament Buildings this morning. My name's Philip McGuigan. I'm the chair of the Health Committee. So it's great to see everybody here. Can I thank you for giving up your time to meet with committee members, to share your experiences with us. Very, very important from us. We're obviously very keen to hear and interested to hear from you today, particularly to learn about your experiences in accessing palliative care services. As you will know, the committee has been conducting an inquiry into this. We've been holding evidence sessions since March. We've been to visit all of the hospices across the north as well to speak to staff and to residents, patients, and all of those working, and that has been also very, very helpful. Speaking on behalf of the committee, I can say it's a privilege to meet during this process with a wide range of professionals to visit and see firsthand the commitment and the passion that everyone working in general and specialist palliative care have. So we know there's great work being done, but we also know from our inquiry, because we've heard concerning information as well, which hopefully as a result of our inquiry and recommendations and report we can help to address. The committee has taken time over months to understand the issues properly, and today is so important in that process as well. So for us to focus today from the committee's point of view is to understand the difficulties faced, you have faced, facing, and hopefully learn some of what has went well also, so that the best practice can be rolled out more widely. Because we want to hear what's working well, we want to hear the difficulties, and hopefully as we move forward and produce a report, it's about sharing what's working well and having that rolled out across the whole of the north, because we know there are some good things happening in some parts that should be happening elsewhere. So this is very informal. This is a big formal building, very impressive building, but in this room today, we're all going to be very informal. So feel free to speak your mind and say what you think needs to be said. So committee members, Alan Robinson, Linda Dillon, myself, we potentially are expecting Danny Donnelly as well, and maybe Diane Dodds. Hopefully they will come at some point. So can I thank Paula from Voices for Care for assisting the committee in arranging this today. Thank you very much. And I'm now going to invite testimony. So we have Alan Shepherd, Claire Marie Passmore, and Kate McConville, who are going to share testimony. Absolutely, that's okay. And as I say, this is very informal, so don't be putting yourself under any pressure. Once we hear a wee bit of testimony, we're going to have a discussion at the tables, which is much more comfortable and easy to do. I hate public speaking. I get very, very nervous.
I'm not sure I with the public speaking if it's work related, but
okay.
It's to do with the personal thing.
No.
It's just a bit emotive.
People think politicians are mad keen to get up and speak in front of a crowd. That is not the case. I completely understand. So, no, as I say, this is very informal. We will have good conversations at the table, so that's ultimately. So, you are?
I'm Kate.
Kate, okay. So, Alan, you're happy enough? And you can stand, you can share it sitting there, you can come up here, you can stand where you're at. It's entirely up to yourself.
Okay, that's all. You're Austin, isn't it? I'm Alan.
Oh, sorry. You put your hand up, Austin.
You're happy to.
Okay, well, we'll go to Alan first of all.
Yeah, can I just come up and find it easier? So thank you, Philip. So I'm here to give testimony on behalf of my late wife, Anne Shepherd, and I just wanted to start with something about the person. She was a wonderful wife, mother, grandmother, and loyal friend to so many people. She trained as an occupational therapist in Edinburgh in the early 70s, but returned thankfully, to Northern Ireland and worked with elderly care people in the City Hospital and the Braid Valley in Ballymena. She worked in community in East Belfast and Castlereagh, and most of her career was with children with physical disabilities at Fleming Fulton School in Belfast and Beech Grove School in Ballymena. She was a woman of immense talents in crafts. What she could do with her hands was incredible. She was an active member of the WI. She volunteered with active listening, with Healing on the Streets, and for a number of years co-led a grief share course in Ballymena. So Anne's cancer journey, I think, is important before I go into what worked excellently, what worked okay, and what I feel needs to be improved. Anne was diagnosed with chronic lymphocytic leukemia in 2010 and had 12 or 13 years of watchful waiting under a really good hematologist consultant at Antrim. And it was only in her last few months she had what I was told was a cytokine storm, which necessitated blood transfusions and zolendronic infusions. March 2020, it's all in our memory, lockdown. And because Anne's immune system was compromised, our lockdown was oh so strict. For 6 months, nobody came over the door. But the one place we wanted to avoid going to was a hospital. But in July 2020, Anne discovered a breast lump, which turned out to be cancerous, stage 3, grade 3. It had spread into the lymph nodes. So surgery, chemotherapy, radiotherapy, and then daily medication for a 2-year period. Emphasize, throughout all of this, Anne was on her own. COVID meant we could not accompany her at any time to hospital. Christmas Day 2020, I spent in the car park of Antrim Hospital, having left her to ED because she had a serious infection. How she did it, what a woman of courage. Anyway, autumn 2022, Anne developed a unproductive cough, and that was initially treated as a cold, then a pneumonia, and then as a pneumothorax. And on the 1st of February, she was sent to Antrim ED for a scan, which showed a mass on her liver, which was confirmed by a triple phase scan a month later. And then there was a series of diagnostic scans, biopsies over the next 2 or 3 months, and referral to a gastroenterologist. On the 2nd of June 2023, we had finally confirmation of Anne's diagnosis, cancer of the liver and pancreas. What I'm told is a cholangiocarcinoma, and she was too weak for any chemotherapy, treatment, etc., except for palliative care. Anne died at home on the 18th of July 2023 with the family beside her. So anything that I'm saying now, it's not about individuals, it's about the system. And I want to tell you there's lots of really good stuff out there. So what went well, and probably I would describe it as excellent. The Northern Ireland hospice specialist nurse, worth her weight in gold. Her knowledge, experience, and advice was absolutely invaluable. She physically examined Anne regularly and was able to provide solutions to Anne's many and developing symptoms, including infections, as her health rapidly deteriorated. She briefed us as a family and carers what could happen next and what to do. This helped take much of the fear and panic out of situations we were to face. She directed us to much-needed practical help through Macmillan Cancer Care, a blue badge, attendance allowance. Her holistic approach, physical, emotional, and spiritual, meant Anne felt that she was seen and heard as a person and not just as a case. We cannot, as a family, overemphasize how deeply Anne valued this. Then there was the NHS, Northern Health and Social Care Trust home care team. What a wonderful team of ladies who washed and dressed Anne in her final weeks of life when she was physically too weak to look after her personal care needs. They did it with immense loving care and great dignity. They made a deep impression on Anne, and as I later learnt from talking to some of the carers, she on them. And then there was the Trust Community Nursing Team, the Waveney team. Their daily visits to Anne to give her anticoagulation injections for clots in her legs was heaven sent. We could ask them questions and get extremely good advice and reassurance. Additionally, they provided alternative solutions when Anne became too weak to go to the toilet. They recommended a top-up mattress to prevent bed sores and a glide sheet so that Anne could be moved more easily about her bed. In the last 10 days of Anne's life, they went what I describe as above and beyond the call of duty, telling us if that we were in any way concerned about Anne to ring them on their own personal mobile phone, stressing that there was no such thing as a false alarm. In her last week of life, district nurses called with her several times a day. So that hospice nurse, that home care team, that nursing team enabled Anne to spend her last weeks at home. This, I can't say how precious this was. What quality time we had with her as a family and her close friends with her. Allied health professionals providing a bath lift, providing a riser recliner chair, advising us on what foods to give Anne to strengthen her. Our Seven Towers General Medical Practice in Ballymena, the staff were all really diligent and supportive in Anne's final months of life. Particularly the many, her medication, her morphine tablets were changing like daily. And so I was saying, look, can you give me a new prescription? And just referrals. And after Anne's death, they looked after me. The hospital diversion team at a place called Rosedale in Antrim. Anne received some blood transfusions there, a domestic setting. Quickly given, on time, no long wait in crowded hospital conditions. Community pharmacy, brilliant. They recognised the urgency of dispensing scripts, and sometimes they delivered it to our house. And Dalriada Urgent Care, in a really life-threatening emergency situation, acted very speedily. We had a home visit from a good GP who arranged an emergency ambulance to Antrim ED. Anne's care that went okay. We had emergency admissions in early 2023 for neuropathy, severe nerve pain down her, I think it was her left side. And then in June 2023 for urosepsis, a life-threatening condition. And we're just so thankful to Antrim ED consultants and nurses for the treatment Anne received there. Anne's current treatment that we feel could have been better, and particularly communication issues. There was a reluctance of some doctors to engage with us on Anne's condition, citing, in our opinion, mistakenly, patient confidentiality. I had held enduring power of attorney for Anne from the beginning of April 2023. But even if I hadn't power of attorney, it's surely vital that families should be involved in conversations about a person's care when they are so sick and frail. These discussions will help us understand what is going on, help us understand what support we can give to a loved one, and potentially alleviating some pressures on the NHS. Help our family member decide on what is best out of all the options available to them. We recognise that there isn't enough money in the NHS, and there never will be, to provide the level of care needed by everyone. We recognise that as society, we all need to step up, but we need to understand what we can and need to do to help a loved family member who is terminally ill. We had great difficulty in contacting the part-time hepatobiliary specialist nurse at Antrim Hospital. And then we had lengthy waits for infusions and transfusions at Laurel House. To us, there seemed to be no forward planning taking place. 8th of June 2023, Anne was at Laurel House for 5 hours, arrived home completely washed out, went to bed. An hour later, we received a call from a junior doctor telling me to get Anne to ED at Antrim as her life depended on it. He wouldn't listen to me as I explained Anne had just been treated. So another trip to ED, a long wait only to be told what I already knew, a false alarm. But the impact on Anne was catastrophic. Next day, she was that emergency admission to ED for urosepsis. 29th of June, we were given a 9 a.m. appointment for a terminally ill person whose carers and district nurses were coming in between 9 and 10:30. Just completely unacceptable. So I renegotiated a 12 noon appointment and was told, Alan, it'll only take 1 hour. Anne was the last patient treated in Laurel House that day, and we left after 3 p.m. In early May 2023, these are all communication issues to me, we were told that Anne was being referred to the Northern Ireland Hospice. We were not told that subsequently it did not need to happen at that point in time. So for 3 or 4 weeks, we were twiddling our thumbs, wondering, why is the hospice not getting in touch with us? Because nothing was happening. I then went to my GP practice and asked them to make a referral, which they did that morning. We could have done with that specialist hospice nurse input weeks earlier. Just what we think are suggestions for improving palliative care in Northern Ireland. Consultants, we feel, need protected time to plan ahead for the care and treatment of patients. Our hospice nurse knew at least 24 hours before Anne was seeing her consultant what her bloods were saying and what probable treatment she needed. But it was only when Anne was sitting in front of the consultant with his computer screen in front of him that he decided what treatment was necessary, which had to be ordered from the pharmacy or from bloods, and this took hours and significantly impacted Anne's health in our view. We need to use much greater use of hospital diversion teams, such as I've said about Rosedale, or hospital at home for palliative care. Improve communication between hospital staff and terminally ill patient families. Whilst we have seen the immense pressure staff are under, this is absolutely critical in our view. Information about what pain relief had been given and when, what referrals are being made and to whom, especially if changes are being made from what was originally agreed. It is our experience that communication pathways between clinicians need to be improved so that everyone has access to all patient records and are also aware of patients' wishes. This is a tough point for us. The minimum treatment for any patient admitted to hospital is to control their pain. Anne was admitted to hospital in June 2023. She was told that she had already the maximum amount of pain relief. Yep, we understand the pressures NH staff are under at that weekend. I think it was a bank holiday weekend, and all the doctors were in ED. But it is our opinion that any patient admitted to hospital who is in severe and excruciating pain should have a written pain plan in place with clear instructions for staff on what to do if things are not working. Anne was squirming about her bed. I was holding her hand. Rachel was holding her hand. We told her, if you need to break our fingers to alleviate your pain, go ahead. The NHS needs to provide contextualised care. We had doctors talking about repeated tests and treatments that were never going to improve Anne's quality of life and had a very negative impact on her at the end, in which, in our view, did her no favours. Then the capacity of the Macmillan Palliative Care Unit at Antrim Hospital. Before the 12th of July, the waiting list was 3. After it, it was 9. Anne was offered a place there the day before she died, the 17th of July, but she was too weak to be moved even by an emergency ambulance. I worked in the health service quite a number of years ago, and I'm aware of the funding of hospices. Public purse provides about 25%. They're very much dependent on us as members of the public for that 75%. And I understand the lack of funds has meant that some beds have been mothballed. We met with the Trust. We met with their senior management. I have written to them. And I know that there are business cases with the department from 2022 to improve the cancer clinical nurse specialist workforce. And while some temporary funding has been provided for the most vulnerable posts, I think a decision is still awaited from the department and the minister. If you can help with that, please do. These are key posts for staff in the hospital and for people who are supporting their family members. Just a few closing comments, and I really do appreciate you bearing with me. I know I've maybe spoken too long. Big picture. Each year around 4,500 people in Northern Ireland die with or of cancer. That's about 1 in 4 of the total number of deaths in Northern Ireland each year. And there will be other people with life-limiting conditions who will need palliative care as well. Small picture, our experience. If you tick all the boxes for a particular illness like breast cancer, the patient journey is very smooth. However, if you don't tick particular boxes, then that journey is much more challenging. And we felt no one really wanted to take responsibility for Anne's case. It was complex. It was multifaceted. Yes, we know the outcome would never have changed in her case, but the journey could have been much more straightforward. I hope you will agree that our society is judged by how it treats its most vulnerable. When I worked in health and social services, the strapline, our motto about why we existed, was adding years to life and life to years. We as a family are so thankful for all the help and support we received. We do not know how we would have coped without it. It gave us precious quality time to spend with Anne as her health rapidly deteriorated. Sometimes weeks, even days, are as important as years. Thank you for listening to me. The testimony about a truly extraordinary, beautiful lady, my wife Anne. We loved her and we miss her loads. Thank you.
Thank you very much, Alan. That was very powerful. We would like to Alan's life justice to us also. We have a number of other speakers. No, that's very absolutely. It was wonderful to hear and so important for us to hear the personal aspects of the people that we're talking about, because we're dealing with systems, but the systems have to produce outcomes for people, and that's why it is. That's why we wanted to hear the testimony that we are hearing today. So I understand this is going to be very hard for people to tell the stories of their loved ones, but we do appreciate you taking the time to do it. So our next person is Claire. Thank you, Claire.
Thanks, Philip. Thank you. That was just wonderful. And particularly where you stressed all the positive, all the great memories. Will you bear with me while I read this, because I want to make sure that I get things across to you. My mum and dad, Jim and Claire McVeigh, died within 6 months of each other in 2020 during the first 8 months of the pandemic. Their combined age was 180, and they were in the 65th year of their marriage. The last 5 years of their lives were marked with deteriorating health problems. Both had multiple challenges, and both experienced an accelerated entry into end-of-life care. Our relationships with them had changed from being cared for to being the carer. Following a couple of ED attendances and out-of-hours paramedic visits in early March 2020, Daddy reluctantly realised that he needed to accept palliative care. Daddy wasn't prescribed palliative care or wasn't moved into palliative care, but we had a chat with him and he accepted that. Despite his wishes and everyone's effort to be at home, he spent the last 6 weeks of life as a hospice inpatient in Somerton Road. He made a bit of a recovery 2 weeks in, but again, despite everyone's best effort, was unable to return to the care of the amazing district and community specialist palliative care nurses, because essential social care could not be joined up before he started further decline. Daddy was blessed with a peaceful passing, and unlike many at the time, with his children supporting his care. Daddy died with various bits and pieces of tubes. He had a laryngectomy, and we were able to actually go into Northern Ireland Hospice to provide the care, because Children's Hospice could look after trachees, but the adult care people. So we had a very privileged position. My 2 sisters and I did a 24-hour rota, and we were there, and they were there at the end. Daddy's end-of-life story has already been presented or published in the Belfast Telegraph and the Sunday Life in November 22. So you can, if you're interested, you can find out a bit more about his history. And as a result of that, I was invited to be our voice in the development of the Belfast Community Palliative Care Hub, where our representation has been very much appreciated and listened to. The hub, I'm so pleased, has had a soft launch. It's not had its big formal launch yet, it's absolutely wonderful. The hub brings together Marie Curie, Northern Ireland Hospice, and the Belfast Trust to attempt to make the best possible palliative care for people in Belfast. I'm very conscious in our palliative and older care forums of those who don't have family carers, who struggle and often die alone. Inequity in access and delivery of care, especially social care, is a challenge very many face. My mum's final days were very difficult for both mum and my siblings. Mum did die from a broken heart, being isolated and not able to be with Daddy through his last weeks. The power of lockdown. From June 2020, Mum received amazing care from the Belfast Hospital at Home team, who are incredible, as you have mentioned. So she received amazing care from them a couple of times. However, in late September 2020, she was referred by this team via ED for inpatient treatment for her heart failure and kidney concerns. Classically released on a Friday evening, Mum's condition deteriorated badly over the weekend and was readmitted to ED on Monday morning. Sent home that evening, no change in treatment. Mum appeared to move very quickly from active treatment to apparent do not treat status very abruptly. It's very painful for me because I took a couple of weeks respite with my husband, who had been seriously ill the year before as well, and I wasn't there during this. So at that stage, her GP apologised and palliative pathway followed. Unlike Dad, however, Mum died at home, at the home that they shared for those 65 years, with good community, social and palliative care. I feel that with both Mum and Dad, poor communication and understanding of their final transition to the last days of life meant that there was undue anxiety for both them and us. I'm a staunch proponent of advanced care planning. I appreciate it is a difficult conversation, but when properly communicated will mean that folks can have their decisions about ending treatment supported and a peaceful, natural death realised and crises avoided. While Mum was safe and well cared for in the hospice initially, they were unable to accommodate him, demand very much outweighing supply, as we've heard. We were also aware of the cost of providing that care, paid for through voluntary donations. And I reckoned that his 6 weeks cost about £30,000. And of course, at that time, we were in lockdown, there were no donations. We raised 4K in a run cycle challenge that even my mum contributed to with her Zimmer. But that won't make a big dent. While most would like to leave this world in the comfort of their own home, it is not always an option due to complexities such in Dad's case. But why is access to inpatient end-of-life care a lottery in short supply, and inequity dependent on, as someone said to me, cake sales? I'm grateful to have been given this opportunity to briefly share the end-of-life care experience of two amazing people that I would love to have ensured was better, but theirs was better than many. There's been a lot learned from my life experience, but in a nutshell, I would like to see more equitable access to inpatient end-of-life care, not dependent on voluntary funding. Joined up provision of services between health and social care providers, including our charitably funded hospice services. No gaps, no duplication, no confusion. Early prompt diagnosis, awareness of that life is ending and of end-of-life needs. Clear identification of the key worker. Alan, you mentioned, your key worker was there, gave you access to their phone number, but my siblings from Australia phoning and asking who's managing the patient, and we had a long list of people to contact, but who's the key worker? And finally, adoption of advanced care planning to assure that all can inform their wishes in a timely manner and smoothly transfer into that end stage of life. Thanks for listening. I came to share this briefly with you because of the work that the Hub are doing, and I felt because of how they listen to our voices, and by sharing our voices, we hope that we'll be heard and improve care. Thanks.
Thank you very much, and good luck with the work of the Hub, and thank you very much for sharing that story of your parents, and we really appreciate that. So next is Linda.
Thanks very much for giving me the opportunity to come and talk about my father, Paddy Kelly. So let me tell you a wee bit about him. My daddy was born in 1937 and he was 85 when he passed away, and he was one good-looking guy. He met and married Mum in 1962. She died in 1979. So he raised 7 daughters single-handedly, and I'll tell you, that's some going. And he was surrounded by women his whole life. He went to the Derry dances in his youth, and he loved to jive. He played snooker, and his nickname was Cautious Kelly because he could make a snooker match last forever. He was there in Derry when Dana won the Eurovision Song Contest, and he met Bill Clinton in 1995 when he visited Derry, and he wrote a poem about him. It was published in the local papers. He loved his garden. Roses were his favourite. He was a DIY fanatic and lived by the motto of, if it moves and it shouldn't, use duct tape, and if it should move and it doesn't, use WD-40. And he believed that Sudocrem was an all-round cure for everything. He was a great storyteller. He loved a good laugh. He dressed up at Halloween and Christmas and parties. He had an encyclopedic memory, and he was always up to date with current affairs. Although he was grumpy sometimes, and who isn't, he was our dad, and we loved him. But in his last days, he was in extreme pain. He asked to die. Every pain and every scream and every tear that was shed tore through our hearts and our souls, and we'll never forget that. Both we and the GP promised him that he wouldn't be in pain, and we failed him, and the system failed us. So let me tell you a wee bit about that journey. So in 1948, the NHS was created by Anya and Bevan to meet the needs of everyone, free at the point of delivery, based on clinical need and not the ability to pay. And Sir Winston Churchill coined the phrase from the cradle to the grave. We all put our trust in the NHS systems and believe that when it's our time comes, that we'll be cared for and we have a pain-free and dignified death. So when I started to train as a nurse, which was a wee while back now, the one thing that struck me over the years was that we had a duty to provide care to all of our patients and to aid their recovery. And when this was no longer possible, to assist them towards a dignified and pain-free death. That was something I worked towards my whole of my life. In Northern Ireland, dying and death is a taboo subject. None of us wants to think about our own mortality and our fragility and our inevitable death. However, none of us can escape it. So therefore, the first experience of many of us have with palliative and end-of-life care is when we are in the centre of it. And it's often found lacking and not what we expect. Even to me as a healthcare professional, my understanding was lacking about what palliative and end-of-life care actually was, and I thought that they were one and the same thing, but they're actually not. So my understanding now is that palliative care is there to provide the patients whose condition is no longer treatable, and it aims to treat the symptoms and provide support for the family and friends whilst they're coming to terms with the realisation. Also to provide the patients also to allow the patients to live their life to the fullest, taking into account the restrictions that they have and providing with both physical, spiritual and emotional support. And the end-of-life care is just that, providing care and support for the patient and their family at the end as the end draws close. This also includes the provision of physical care such as washing, feeding and administering medication. Also, most importantly, pain management, which can be a fine balance to control pain whilst allowing the patient to spend their last days with their loved ones in a meaningful manner. And we only understood this whilst my daddy was in the middle of it. So Dad had been ill for many years with various health conditions. He had heart failure following a heart attack 20 years previously, but in the last years of his life, his condition slowly deteriorated. He lost weight, he'd had poor appetite, his mobility decreased, and he experienced what he thought were side effects from his medication. However, now, in hindsight, he was displaying all the symptoms of chronic heart failure, and his medication became less and less effective. Although all of this, through all of this, in his mind, has remained very, very sharp, and he held out hope that eventually the medications could be changed and control these symptoms, because he wanted to live till he was 100. So in May 2022, he was again hospitalised with distressing symptoms of vertigo, breathlessness, and following investigations, consultant explained to him that there was nothing else they could do to control his symptoms, and he was moving towards the end of his life. So he was then we all wanted Dad to come home. So he was admitted home, and then one night over the weekend, so this happened to be, unfortunately, the weekend of the Queen's Jubilee, and it was a long bank holiday weekend. So I can see everybody that's already talked here today has talked about the lack of cover at weekends, and we experienced exactly the same thing. So this particular weekend, due to exceptional circumstances, there was no Marie Curie nurse available, and that night Dad was again in acute pain, and the on-call GP said he would come to the house to administer pain relief. As Dad was in acute pain, we assumed that when we were told the GP would be coming out, that it would be as soon as possible. It was 2 hours later, and after another phone call from us, that he arrived. He was also carrying out home visits for other patients, as well as looking after palliative and end-of-life care patients. His call sheet noted that Dad's call was urgent, and 2 hours was written in the comments box beside that. So although it was an urgent call, they were given the 2-hour window, and we weren't aware of that. But all this time, Dad was in acute pain. The nurses that cared for Dad in his final days were caring and compassionate, but it was very evident that they were stressed because they couldn't deliver the care that they knew he needed. The Palliative and End-of-Life Care Living Matters, Dying Matters strategy talks about a holistic approach to individualised care, but this is impossible to deliver when you have to travel up to 30 miles between patients to deliver the basic care. There's little time for emotional support for the patient and the family when your next patient is waiting for you, possibly in pain as well. So on Sunday the 5th of June, it was finally decided that Dad needed to have a syringe driver for pain relief. The drugs protocol stated that a patient had to receive morphine 3 times in 24 hours before a syringe driver would be considered. Whilst I understand the reasons for protocols, this protocol was very rigid and not flexible to the needs of the patient, which is our Dad. It was obvious from early on that he would require a syringe driver at some stage. However, not all the drugs that were required were in the house. So on the very day that Dad died, we were away again for 2 hours to get his medication. His syringe driver was erected at 1 p.m. and he died at 3:15 that same day. None of these services, or indeed the staff, started out with the intentions to cause obstructions or delays. However, the system was set up in such a way that these are inevitable. Every service and staff member that we encountered, although professional, caring and compassionate, didn't realise how their role was key in delivering the care needed to my Dad. There was no real sense of a joined-up approach, just different cogs, all doing their thing, but not really engaging. There are national strategies for maternity care, cancer care, mental health. Most of us will never have to access these services. However, the one service that we'll all have to be exposed to in some way or another is palliative and end of life, which doesn't have a current strategy. It has a strategy that was in place that has been reviewed, but it needs to be reviewed again. To ensure that services are delivered and when they're needed, strategies need to be live, they need to be reviewed regularly to ensure that they're still relevant. There's a great urgency for a new strategy for palliative and end-of-life care, considering the post-COVID world where new challenges and gaps in the current services were identified. The strategy still needs to be created with input from service users to ensure it delivers where the patient needs, and its focus needs to be on working together for a common purpose. So, some of the suggestions that we had as a family, and come of my own background in nursing, is that change doesn't have to be big. Small changes can have a huge impact. Direct contact with the GP for the nursing staff. The nursing staff had to ring, the palliative care nursing staff had to ring into a centralised number, wait for the GP to get that message, and then the GP would ring them back. There should be a direct line. Now, I know we've done some work with the Western Trust, and I do know that there are direct line contacts available now for the nursing staff, because that cuts out a part of that process that doesn't need to be there. Nurse prescribing. Why can nurses not prescribe certain medications? They prescribe them in hospital situations. Why can't they do that out in the community area? The nurses are still the same qualified nurses, they're experienced, so why can't they do that? I know there's protocols, etc. around that, but that needs to be something that needs to be pushed forward quickly. Prescription delivery service. So I know there's a prescription delivery service, however, there's nothing there for urgent. You could be waiting for a day, you could be waiting for 2 days, or whatever. Electronic prescribing. We are all using laptops, we're all using PCs, I see them in the room, so why can't we do electronic prescribing? What is all this paper about? Collect a prescription, take it here, take it there, take it everywhere. A telephone tree or an online medication stock availability system. So we went to various pharmacies on one day alone to try and get the prescription that my daddy needed, and nobody had everything that he needed. And they wouldn't let me take that prescription to another pharmacy once I'd taken it there. So nobody ever offered to say, oh, sure, I'll phone and check if Boots have it or whatever. Nobody did that. We ended up running around half of the town while Dad was in pain. So a telephone direct, in other words, somebody here could say, well, I'll ring that pharmacy so you can go directly there. A centrally, fully stocked pharmacy, 24/7, possibly located in a healthcare facility for those urgent medications. Adequate staffing based on workload and clinical priorities. The older population, there's more and more people requiring palliative and end-of-life care. Robust and flexible drug protocols. So again, as I said, Dad had to have morphine 3 times in 24 hours before they would even consider a syringe driver. And in that time, he'd had lots of breakthrough pain. So you need to be flexible because these are different circumstances. Raising public awareness of palliative and end-of-life care and how they can be part of it, because we as a family didn't realise that you can be in palliative care from the day and hour you're diagnosed with a condition, because it's there to provide you with support to live your life as you are. It is not end-of-life care, but the public don't know that. We didn't know it as a family, and I know the public don't know it. Palliative care can be instigated at any stage. And so what I told you about Dad being in pain in his last hours, try to imagine if he was your loved one, and please don't let anybody else suffer unnecessarily. And thank you very much for your time.
Sounds like a wonderful man, although I definitely wouldn't have wanted to play snooker. No, he definitely wouldn't. He sounded like Steve Davis, I was more a Jimmy White type player. And obviously we all agree that soda cream is the cure for everything, and who doesn't agree with that? So lastly we have Austin. Thank you.
Thank you, Mr. Chairman. Ladies and gentlemen, I didn't come prepared with a testimony, but fortunately I have a testimony. Once I read the word, I started to rewrite my testimony. Just firstly, I'm a specialist parish art dealer. I've been for the last 45 years. My late wife was a nursing sister on a cancer ward, and she had Alzheimer's, not suffered. She had Alzheimer's for 14 years, and from the day she was diagnosed to the day she died, she was never in a nursing home, she never had a urinary tract, she never had a bed sore, and I had the joy and pleasure and privilege of caring for her. That was rather special to me. I want to give you a fourth P, which I think is the key to caring: having a positive mental attitude. From the day she was diagnosed, I took it on board to take responsibility for her care, in that communicating with the various consultants, with the various doctors, and also the hospital. She was never in hospital. The other exciting thing is I discovered a wonderful mantra for caring. I have a friend who's an A&E consultant. We're very close, and I discovered that the NHS was the key to being a good carer. Nutrition: be fussy about what you eat. Hygiene: be meticulous about your hygiene. 90% of infection comes through the mouth. And as Kieran said to me, the last thing you do before you touch Elsie is wash your hands. That's what I did. Now, what would the third thing be? NHS. Stimulation. And I made a positive attitude, or a positive point of getting her out of bed every day till the day she died in my arms. She was even out of bed that day. And the last 3 years, when she was in a wheelchair, I had the joy of monitoring how people treated people in wheelchairs. I found that they talked to the person pushing rather than the person in the wheelchair. So now I'm actually volunteering, by the way, for Belfast Hospitality, talking to cruise ship passengers coming back to the ship, getting their feedback, what was good about it, what was bad about it. And when I see a person in a wheelchair, I make a dive for them and talk to the person in the wheelchair, and they're just so pleased. Ladies and gentlemen, I want to encourage you in your world of caring. Use the NHS. Thank you.
So, thank you very much, Austin, for your testimony and the words about your wife, Elsie. So, that now means we're going to go on to discussion. So, we're going to have about 25 minutes of discussion. So, we've actually heard a lot. To be honest with you, there was an awful lot of detail in that. So, we can just have a bit of an informal discussion. If there's anything else that you want to say, obviously the MLA should be asking questions, and we'll try and tease out any more information that will help us moving forward, and then we'll break for lunch at about 10:02. Okay, so just at your own tables. Oh right, okay. So what we're actually going to do is, sorry, I apologise. You think I would know how? You think I would know? This is why our public services are crumbling. Really just don't know what's going on. So, sorry, I thought we were going to be talking at seven tables. So what we're actually going to do now is just, it's a small enough room, we can just open up a discussion. So we're just maybe turn our chairs in a way that we're looking at everybody. So, I mean, I'd probably start. So everybody's talked about communication being a problem, and obviously it's very important for families and for loved ones who are at the end of life, that they aren't wasting time trying to seek information, get the right person to speak to. So I would be keen to hear how you think the system could be improved. What? I mean, we know we need improvement in terms of you know, information, but how in practical terms you think we could do that? So go ahead.
Well, do you know what? Because I work in the health service, I can see this every day. And what I believe is that our medics should be trained at their training stage, that their communication is required, and they shouldn't be afraid to ask those difficult questions or to tell patients what they need to know. Nurses, we again need to have better communication in our skills about how we approach patients. But I mean, somebody here today, I think it was yourself, Linda, mentioned that they were getting a diagnosis and they beat around the bush and never once said the word, "You've got cancer, you've got a tumour," until they were actually asked face to face. So education is key to this as well, I think. I mean, I'm not talking about what's already in place, I'm talking about back to the day whenever people are coming in to train. Palliative care should be part of that training without a doubt. They should be able to hear testimonies from people who've been through similar circumstances to help them build up this compassionate personality that they need to have to do that job correctly.
Does anybody else want to talk specifically on that point of communication?
My husband Stevie had head and neck cancer and had a tumour in his cheek. Whilst he was in treatment, it was amazing. The quality of care, I couldn't fault it. We had a Macmillan nurse who coordinated everything and kept all those plates spinning, all the different agencies and service providers that he had to engage with. As soon as we were told they couldn't treat him any longer, there was nothing. We left that room with the worst news, but no appointment, no name, nobody to talk to, and our Macmillan nurse said, "Thank you, I've enjoyed working with you, I hope it goes well." But there was nothing. We sat in the car park and cried. Our ticket ran out, we had to buy another one. And we met people eventually who were great, but for that moment, when you needed it most, there was no name to cling to, no time that you'd be talking to somebody, and that was cruel. It was very cruel. We met wonderful people throughout palliative care, but nobody was coordinating it. We lost that, and I had to keep all the plates spinning, and I didn't. I made so many mistakes, and I was broken by that. Having someone, a key worker, a link worker, is essential to keep it going. And pain relief would be the second one. That's come up again and again. It's frightening how often the same things are being said and they're not changing. Stevie had to go into hospital to treat an infection with intravenous antibiotics. No matter how much I'd said to the nurses and doctors that it was an incremental approach to improving to his pain relief, they walloped it up. He ended up like a zombie and had no quality of life in there. To get it back to where he could, we went to the hospice and had to have it dropped down. Huge amount of pain to get it back up again. Transition from the hospice to back home again was a nightmare. His script was 1,000th of what he needed when he got home. At a weekend, same conversation again. What happens at a weekend? It was took to the Wednesday before he was discovered that this error had been made. And then he had another week of pain to get it regulated. So if we're still talking about communication support and pain relief, needs to be addressed. It really does. Sorry, I didn't mean to get so emotional. But it was frightening to me today. Stevie died 5 years ago coming up, and we're still talking about the exact same issues. And I've been fortunate enough to work with the Palliative team. There's improvement service, and they are making changes, but I don't know if they're actually happening. That's what I'd like to hear more about, really. From that 5 years ago, talking about collated information. I hadn't heard of a diversion hospital nurse until I was in the place of who can help me, and only heard by accident somebody knew somewhere. Hopefully that's better now. Hopefully that's improved.
The key point of what we're trying to do is make those improvements, force through those improvements, and also ensure that the senior is good somewhere else, so that everybody has equal access to the same treatment. Apologies, I should have said at the start, everything that's been said has been recorded. Hansard here are recording everything, so I mean this is very important for us, so that's why we're using the microphone, so it makes it easier for everything to be recorded through Hansard. So does that, go ahead, Alan.
One of the points that was Alan made reference to his dear wife, specifically around the waits, Alan. You had said that there was a long wait in Laurel House, and there was also a waiting list in Macmillan Unit in Antrim. And I'm keen to hear from others in the room what their experiences were in terms of hospice care. Did they have similar waits? And again, how did that affect them, and how did it affect the welfare of the patient, obviously?
Even respite services for children getting into the hospice care. Now, my daughter passed away 24 years ago, so I know things have progressed on, but I still don't see a massive progression. The new Encompass system within the trust is supposed to be able to draw professionals' opinions and diagnoses, and everything's supposed to be on the one screen, but it's not. Things are not being highlighted about the patient for another professional to deal with that. And that's the whole idea of that system, was that everything was mapped out about that patient, and that everything was to be highlighted about that patient. The pain relief was supposed to be, passed on quicker. Palliative care was pathways were supposed to be smoother, and I unfortunately have had years from my daughter. We have a genetic condition, so my niece and everything I've seen go through palliative care. My sister died of cancer. So the system is not changed very much in 24 years that I've seen. And I work within the health service, and still there's frustrations at a nursing level that consultants are not updating the system to pass on the information, and that we feel that we're having to try and pull that information about that patient, and that we're spending more time in front of a computer than we actually are then caring for our patients.
Very important. Sorry, I should have also said, just for the benefit of Hansard, if you're speaking, can you introduce, just say your name before you speak. So does anybody want to come back on it? Go ahead, yes.
Claire Marie Passmore, if I could just follow up on Alan's question about times to delay. There's two issues with communication. One's the systems, and whether our new all sparkling Encompass hopefully might address some of that, as long as it works. The other is personal communication. But one of the things that I'm keen to make sure is that when somebody is referred, that both the system flags them, and that the person-to-person communication, and what we have got to do is to make sure that the backups there, or wherever it is that we can measure that, because it did take for in Dad's case, and I don't know whether I'm always blaming the pandemic for this, but from we made the phone call when we found the route through his cancer services to palliative care services. It took a while to do that. Then that was triggered Northern Ireland Hospice. In the meantime, he had another incident, and the paramedic said, would you think about referring him to palliative care? And I said, yeah, we did that, and we're still waiting. One of the big challenges they have is capacity, and we need to make sure there's capacity there. And as I tried to say, the big challenge we have is the number of palliative care inpatient beds that we have, and the fact that those are 75% voluntary funded. So that's a big issue in terms of delay, and certainly with Dad, that was part of the delay, because there wasn't an appropriate bed for him at the time.
Yes.
Hello, Kate McConville. My father was transferred from the Regional Cancer Centre into the community without a handover or any kind of referral. For 2 weeks after he'd been told he had weeks left to live, he was self-medicating with ibuprofen and paracetamol when he should have been on long-tech morphine. By the time Macmillan called out to see him, they were astounded at the fact that he'd been left with no transfer of care. We never received the service we should have done because of the rurality, because of where my parents lived. And Macmillan called out twice, and then they never visited again. And we only had telephone support after that, which was daily to check on his medication. We never had a key worker. We were never told there was a key worker. And I had to communicate daily between GPs, allied healthcare professionals, the Macmillan nurse, not really knowing who was responsible for what and how things happened. Community pharmacies did their best, but they weren't perfect. And they didn't on weekends or after 5 o'clock in the evening. They couldn't provide the service that we needed when we needed it. Now, I was told there was a twilight service for pain management between the hours of 5 and 7. One particular evening when my dad was screaming in pain, I rang the twilight service only to find that nobody answered. And for 2 hours we were left with nothing. I had to make decisions about breakthrough medication that I shouldn't have had to make as a lay person. I have no medical training. Was reassured that I made the right decisions, but I could have made the wrong ones, which would have resulted in the death of my father. It needs to be better. We need to do better, generally, as a service. And that's not just trust-specific for the Southern Trust. That's across the whole of Northern Ireland. We're not learning any lessons, and it's clear today from what other people have said that we've all had similar experiences, which means it's still continuing. And that was in 2022, so it has to be better.
Thank you, Kate. I was going to ask you what trust area you were in, and I was going to ask, my next point was on the rurality and differences between rural and urban, so I think you've clearly identified some of that issue as well. Linda, you want to come on that?
Unfortunately, from what you said, even though I hadn't asked you where you were from, I could have told you it was a Southern Trust area, because I had exactly the same experience, and it was a question I was going to ask, was that issue around who does what Macmillan does. So in the Southern Trust you had Macmillan, you had the district nurses, you had the twilight service, you had the Marie Curie nurse, and nobody in my family, including myself, knew who did what. And so I suppose it's trying to get a sense of, is that the general experience, that people are not being told who does what? And I'm not sure even those professionals know among themselves who does what, so that if you accidentally ring the twilight service, that they can say, actually, it's Marie Curie right now, or it's the district nurse tomorrow. And you're right, that's not always a timely response, but I suppose just getting a sense of is that the experience across the piece, or is that Southern Trust specific?
Yeah, that would be our experience, I mean, I worked in the health service at a senior level, so I had some understanding, but we chose to use, fortuitously, our hospice nurse as the key worker, and she was excellent. So, you know, she told us who to go to, what to do. If we hadn't had her, I mean, we would have been just pillar to post. Yeah. Yeah, yeah, so, you know, with me, with a bit of knowledge, I struggled big time. And it was just by accident, because I know other people who maybe haven't used their hospice nurse as the, in quotes, key worker. They've been just, they don't know what to do. So Alan Shepherd there.
I'm actually an MLA, so I'm here asking you the questions, but it's just to make the point that, you know, even in my position, I wasn't aware of who did what. So I think I think for anybody out there, and for people who have family members who can represent them, that's great, but what about the people who don't?
We have actually heard from a senior consultant who's told us that even with his experience within the health service, he struggled to navigate. So it's a big problem. I mean, if people like yourself and senior consultants and MLAs, elected reps, are having find a difficulty, then you can imagine how difficult it is for other people. So anything? Yes, go ahead.
So what I was going to say is that if palliative care is done correctly, and it's started at the start of the journey, and the patients get what they need to support them, and the family get the support and the follow-up support, because the families are grieving. I hear people talking 10 years ago, 20 years ago, and they're still grieving about the same things that they went through. But if palliative care is done correctly, then it reduces patients' admissions to hospital, because we already know we're under pressure. The ED departments are under extreme pressure, and that is not a place where somebody who is at the end of life sits for 6 to 12 hours waiting to be seen in pain, because nobody can give them their pain relief. But if you have palliative care in the right place at the right time, then those patients won't end up going to A&E. And it is well documented that the instances of patients going to A&E and having hospital admissions in their final months of their life is extremely, it's elevated there, but that's not the place they need to be.
One gentleman that I looked after in the community died about 6 weeks ago. Sorry, Tammy Snodden. Died about 6 weeks ago. The family were only told that he was on palliative care pathway 24 hours before the man died. They did not give the family the choice to bring him home again. They did not give the control to the family. And I understand within certain circumstances, certain cases, that they can't give the family that, but at least inform families. You know, the palliative care is something that, communication keeps coming up again and again and again.
So in terms of palliative care, I am a great advocate of advanced care planning. Because you know what the patient wants, what the family wants, and there's no fuddling around whenever that patient loses consciousness. Do they want this? Do they want that? Do they want something else? Having those conversations up front, but not everybody can have those conversations. You have to be trained to be able to ask the right questions and to get through and to make sure the family understand what you're saying, to be able to speak at their level. And that's all to do with education. I feel education is key to everything we're talking about today.
I've, Claire Marie Passmore, I've already said how strongly I believe in advanced care planning, and I think it has to start before palliative, but also it isn't just a conversation between the patient, the carer, the clinician, because it is going to be a difficult conversation. And I sort of did that a bit with my mother and my sister sitting in my car saying, right, Mum, what wants to happen? And she was already down the road. So I know that that advanced care planning the conversation has started in Northern Ireland. It seems to have drawn to a halt. And it won't just be a health matter. There's so many other things that are involved in that. So it will be healthcare, it'll be social care, and it'll be civil community, because it's going to be a difficult conversation, and we've all got to be there so that we make sure that there's nobody's left behind and that the wishes of the individual are followed.
To give you my name. So in terms of advanced care planning, it's about making people understand that when you're putting palliative care, that's not you knocking on heaven's door. You know, there could be a long, long life in front of you before you get to that stage. I'm a member of Voices for Care, and we published a book just coming up to Christmas last year called Positively Palliative. And it's a book of people talking about how they've lived with palliative care and they've had long lives. But it also talks about people who've had poor experiences with end of life. So it's about making the public aware, because as soon as somebody says to you you're on palliative care, you're just out there choosing your songs for your funeral and picking out your coffin, you know, where that's actually not where it should be.
There's one area, Alan Shepherd here, that maybe we haven't covered, but I feel I need to say it, and it's a positive. It's the help of the community. Our circle of friends, my wife, as I say, was in the WI. She had a coffee group of ladies, and the number of times there was a rap at our door, and our front step was like an altar. There were food parcels, there were meals left on it. You know, when you don't know what you're doing, the fact that you don't have to think about what am I going to cook tonight was great. Some of Anne's people who trained with her in Edinburgh, who were all over the UK, actually flew in when we knew she was in her last weeks, just to say hello, just to say how much they loved her. And so those little things are the things that helped. And Anne was a deep woman of faith, and just the care that hospital chaplains, our own minister, Rachel's pastor gave, just, you know, dealing with all the aspects of a person's, you know, the physical, the mental, the faith, the spiritual, I think is so important on that journey.
That's a good moment, good positive moment to draw everything to a conclusion. So, without repeating everything that has been said, like we did identify earlier on, that palliative care is a in some cases in the north a taboo subject. People don't like talking about it. So the conversation today, I think, from us, from our point of view as an assembly committee, that is doing this inquiry has been extremely useful. So we really do appreciate every one of you coming along and sharing your experiences, both positive and negative, and talking so passionately about what you want to see happening, but also talking so lovingly about your loved ones. I think that has been extremely useful, and we will have jotted everything down, and it will be extremely important and helpful for us in what we were doing. Our job is to collate all of what we're hearing today and all of what we've heard over the last number of months and put it into a report with action plans, which actually does what we all want to do, is make a difference bit by bit until we get that system that everybody living here deserves and can improve palliative care and end-of-life care for everybody's family, whether you live rurally, urban, regardless of whatever trust you're in. So we're going to maybe break now. Well, we are going to break now. We're going to possibly try for a photograph. If people want to stand in a photograph, that would be good. If you don't, we completely understand that as well. I think we're maybe going to. The tradition is when you're here, you have to go out and stand on the balcony, and then we're going to have a bit of lunch. So thank you very much.